Thank you. So can everybody hear me okay? Yes? Okay, good. So sometimes I speak too fast or if I mumble, so if I do that, somebody put your hand up, let me know, or if I need to repeat something, please let me know. So as Dr. Yan said, we're going to talk about space-time patterns in malaria and targeted interventions for malaria on the Thailand-Myanmar border. And the way I've organized this talk is first I'll begin with an introduction to the malaria situation on the Thai-Myanmar border. I'll move into some microepidemiological work where I talk about vector exposure and reactive case detection, which I'll explain a little bit in some slides coming up. Then I'll move into some community level work, talking about early diagnosis and treatment for malaria and mass drug administration. And then I'll move into future directions where I kind of hope to tie up the loose ends from both of these levels, looking at non-traditional targets for mapping and interventions and targeting the remaining reservoirs of malaria. And then, of course, some conclusions. But overarching all of this work are these concepts of spatial scales, which in many ways are heavily driven by population movements, both humans and mosquitoes, though I normally focus on humans. Scalability, so does something that worked at a small scale, can it be done also at a bigger scale, or can it be reproduced so that it fits into a bigger scale? And then most of what I do is what we call operational work, but might also be called translational work. That is, I try to bridge the gap between pure science and applied science, and do so in a really fast way so that we can apply it to targeted interventions in the field setting. So probably most of you already know about malaria, but just in case some of you don't, malaria is caused by infection by a Plasmodium parasite. It's spread by Anopheles mosquitoes. And there are 4 main human malarias up here. That's Plasmodium falciparum, Plasmodium vivax, Plasmodium ovale, and Plasmodium malariae. And sometimes this one gets included. That's Plasmodium knowlesi. It's a monkey malaria, but in some places of the world, like in parts of Borneo, you see a lot of it in humans as well. Moving now to the greater Mekong subregion, so that's this area here, you can see that throughout most of the area, there's relatively low transmission. So the yellow parts are where you have about one or less cases per 1,000 people per year of malaria. So that's pretty low transmission of malaria, and that's for most of the area. But the other big thing that you can take away from this map is that it's highly heterogeneous. So if you look at Myanmar, which is this country here that's labeled with the number 1, you can see that there's relatively high transmission there. And then right next door in Thailand, where I spend most of my time, you can see in the middle, there is almost no malaria. In much of those central provinces, there hasn't been any malaria for several decades. But along the borders with Myanmar, also with Cambodia and with Laos, there is malaria, endemic malaria, which is presumably related to some spillover effect from those neighboring countries that still have a lot of malaria. Then moving in, if we could zoom in a bit on the Thai-Myanmar border, you also have the same situation. There's relatively low transmission. So the town that I spend most of my time in, Mae Sot, there hasn't been any malaria there for decades. But if you move out of the town, just about 30 minutes worth of a drive, there's some pockets of really high transmission. There's also very diverse vector species. So it's not just one mosquito that spreads malaria here. There's 3 different complexes, each with about 10 different sister species within each complex. You've got Anopheles dirus, Anopheles maculatus, and Anopheles minimus. Each of these inhabit slightly different habitats, have slightly different feeding behaviors. And there are some risk factors. So anecdotally, the forest has been associated with malaria. So it's thought that people who live near or in forested areas or who travel into forested areas have a greater risk of malaria infection. Although a lot of that is anecdotal. There's not been strong evidence of it. It is the case that adult males tend to be disproportionately affected with falciparum malaria, which suggests some kind of occupational exposure, for example. And also hill tribes. So ethnic minorities that live along the Thailand-Myanmar border tend to have much more malaria than either Thai populations or Burmese populations. And while this isn't really the topic of this lecture, or this seminar, the area really is a hotspot of drug resistance. So time and time again, drug-resistant strains of falciparum malaria have emerged in this area only to subsequently spread to other parts of the world and resulting in public health disasters. And right now, we have one antimalarial that still works. That's artemisinin and the artemisinin derivatives. And we're already finding drug-resistant parasites, parasites that are resistant to this artemisinin. And so one approach is Since we're not going to have another drug probably for 10 years that will work, and we're losing the ability to use this drug, then our approach, or one of the approaches, is to just completely wipe out those falciparum malaria parasites from this area. And that's what a lot of my work has been geared towards. So a bit of context. Most of the populations along the Thailand-Myanmar border are hill tribe or Karen. This is a typical Karen village. So we've got a village here and some rice paddies around it in the hills. A Karen house usually looks something like this. Most of them are built on stilts. They're very open, very comfortable in the tropics, actually. You can see we've got some hammocks underneath. It's a nice place to hang out. Villages look like, basically like this. But it hasn't always been a nice place. There are several different armed groups in the area. So this is the Karen National Liberation Army. There's also a Democratic Karen Buddhist Army. There's a Border Guard militia force, and then the Burmese military. And what's been happening is that the Karen have been fighting for their own nation for a very long time. They were a part of the longest ongoing civil war in recorded history. So over half a century, they were fighting with the government. Recently, there have been efforts towards peace, though not everybody has agreed towards that. And as a result of this fighting, of this conflict, you have several refugee camps. Today there are 9 refugee camps on the Thailand side of the border. This is a small subset of the largest one. This is Mae La Camp, and at one point it had over 50,000 people in it. Today there's about 35,000 people still. There are also IDP camps, that's internally displaced person camps on the Myanmar side. And so these are major population movements that happen all in a really short period of time. But the border is really porous anyways. People move back and forth all the time. Many Karen people will have a house on the Thai side and farms on the Myanmar side, or vice versa. Movement is constant, back and forth along the border. It's marked by a river in most places. And as with other border areas, there's a lot of smuggling that goes on, illegal smuggling. So this truck here, if you can see that, it's backed up to the river. There's a boat behind it, and it's got a giant teak tree that's presumably been cut down in the Myanmar forests. So all of that to say, it's a complicated place to work. Rolling out a malaria control system, or let alone an elimination system, is complicated for lots of reasons. And so I'll give you a couple of definitions. I keep saying, I talk about control, about elimination. What I mean by control, malaria control, is it means that there's some kind of a public health intervention that brings malaria down to a locally acceptable level. So it's not out of control. It's not just epidemic. There aren't hundreds of thousands of people dying or anything like that. It's not completely getting rid of all of the cases. It's just bringing it down to low. Seasonal malaria, for example. And then once you have it under control through some kind of efforts like clinics and hospitals, you can start thinking about elimination. And this means that for some defined geographic location, you're actually bringing the cases down to 0, and then you reorientate your interventions to preventing the reestablishment of transmission, because there will be other geographic areas that still have malaria, and there will be human movement between those different geographic regions. And then the last definition here is eradication, and this would mean that you've actually eliminated, you brought cases down to 0 in all places so that no further interventions are necessary because there can be no more reintroduction. What we've been working on mostly is elimination. You could think of these as sort of a roadmap towards elimination. We start off with control. The World Health Organization gives this, it's kind of arbitrary, but a slide positivity rate of less than 5%. So that would mean that of the people that come to the clinic with a fever, you make a slide, roughly 5% of those wind up being malaria or less. And once you have it under control, then you can start thinking about pre-elimination, which might be with less than 1 case per 1,000 people per year. So that would be, if you think back to that map I showed you of the greater Mekong subregion, that'd be a large chunk of the greater Mekong subregion. At that point, you have a program reorientation where you start thinking about elimination. And so it's going to be a little bit different than just having sick people come to the clinic. You actually need to go out and find where the reservoirs are to get rid of it so that you can bring it down to 0 local cases. And then if you're a nation, if you're actually a country, if that geographic unit is a country, and you hold it at 0 cases for 3 years, then you might be able to get World Health Organization certification of having eliminated malaria. So recently, Sri Lanka was able to achieve this. At that point, there's another program reorientation towards the prevention of reintroduction. So at that point, you're still going to have imported cases from time to time. You just don't want those imported cases to take hold so that it's endemic again. You can think about in the US, in certain places, we still have Anopheles mosquitoes that can spread malaria. You still have people that can get malaria. And sometimes it's even imported. So around an airport in Dallas, Texas, you might get a little outbreak of malaria. But it doesn't stay. We don't have endemic malaria in the US because there's quick case reporting and case investigation. Something is done about it to prevent the complete reintroduction. So all of these elimination strategies are based on two main sub-strategies. One is blocking human vector contact. Usually this is done through long-lasting insecticidal nets or through indoor residual spraying, so spraying for mosquitoes inside a house. And the other approach is through reducing the infectious period. And note, I say infectious period, I'm not talking just about infections because treating an infection in itself is an individual medical intervention. So you're treating the person so they're no longer sick and so that you're reducing that individual's morbidity and chances of mortality. That's important, but for this case, what we're talking about is a population level health, and we don't want them to transmit to someone else. You still do this through treating infections, and there are different approaches to figuring out where those infections are. How do you actually detect them so you know how to treat them? One is passive detection. This is passive case detection, and this is the most common approach that you see. You could think of it like a hospital where you have a catchment area, and when people get sick, presumably they're symptomatic from the malaria, then they wind up at the hospital, they're able to get diagnosed and treated. Another approach, though, is active case detection. And this is, for some reason, you have gone out into the community, a defined community or a defined area, and you actively test people, regardless of whether or not they're sick. You screen them to see if they have malaria and then treat them if they do. A variant of this is reactive case detection. I'll discuss this a bit more, but it's kind of a hybrid between passive and active case detection. And then another approach altogether is presumptive treatment, where you treat people regardless of whether or not you have actually tested them for malaria. In some parts of the world, in some parts of sub-Saharan Africa, if somebody shows up at a clinic with fever, it's most likely that they have malaria, so you give them antimalarials. And where I work, we don't do that, but what we do sometimes do is called mass drug administration. That is, we know that this community has a whole lot of malaria, and we go in and we give everybody antimalarials regardless of whether or not they feel sick, without testing, to see if everybody in the community has malaria. All of these approaches are inherently spatial. So mosquito nets, for example, work inside of mosquito nets, of course. Passive detection works within a catchment area, and if that catchment area is really large, especially if you're in a remote rural area like where I work, then if it's really large at the edges of it, it's probably not going to work really well because people who are feeling really sick are not going to walk a long way to get to a hospital. Active case detection, you actually have to define some kind of a spatial unit, as you do with mass drug administration. So the microepidemiological work that I'll present here, there are two main questions. One is, when and where does vector exposure occur? And the other is, does spatial targeting of cases work at small scales? So this will be a part of the reactive case detection that I mentioned previously. First off, the study design, we started with 16 villages in Karen State. I'll show a map in just a second. We did surveys in the villages. So we went in, we took whole blood, about 3 milliliters of whole blood, and then we analyzed that blood with quantitative PCR, an ultra-sensitive quantitative PCR. From that, we were able to estimate a prevalence of malaria, and 4 of those villages out of the 16 had prevalences of higher than 40%. So almost half the people in the village had malaria. Most of them were asymptomatic. Those villages were targeted for this pilot work. We set up a demographic and geographic surveillance system, which means that every individual in the community that participated, which is the vast majority of them, wound up with a unique identification code. Each household in the village wound up with a unique identification code, and then we took GPS coordinates of every household. And individuals can then be tied back to the household, and if you have cases, you can map them to the household. We also set up a community-based malaria clinic. We call these malaria posts. I'll talk in more detail about it, but it's a very simple place that people can come get free early diagnosis and treatment within their community. And we did a mass drug administration in all 4 villages. We started with 2 villages at month 0, and then we did the other villages at 1 year. And we did follow-up blood screenings in all 4 of the villages every 3 months for the entire duration of the 2-year period of time. And along with this, we did some entomological work and biomarker work. The biomarker work in particular, we were looking for immune responses to Anopheles saliva. So it was a new biomarker, And if people are getting bit by a lot of Anopheles mosquitoes, that's the mosquito that spreads malaria, then they should have this biomarker in them. So if you have a higher response of the biomarker, you get bit by more Anopheles mosquitoes. This is what the study site looks like. So this is where I spend most of my time. This is Mae Sot. This is where our field unit is located. On this side is Thailand. On this side is Myanmar. And the 4 study villages are indicated by black triangles. So this is Kenota, Tupanya, Tikoto, Taota. And I zoomed in on them over here on the left side. Each little ring here, these little gray rings, those are households within the community. The red cross, that indicates where the malaria post is. And the blue squares are where we have catch sites for mosquitoes for the entomological work. Now, each of the catch sites, we would have 2 teams. There'd be a team inside and outside of a house, and they're catching mosquitoes. This is human catch landing from 6 p.m. to 6 a.m. for 5 nights, for 5 consecutive nights, for every month during the study period. These guys would be hanging out at these spots. Not with chopsticks. No, that'd be very nice. They literally sit there all night and they watch each other. And when a mosquito lands on them, they have a little vial. They catch the mosquito, they cap it, and they write the time that they caught it. And then those vials, they go back to the lab. Somebody morphologically analyzes them at the species level, and then they grind the mosquito up and see if there is a parasite DNA inside of it. So we know if the mosquitoes are actually infected. And the first results we got from this, I'll try to take my time to explain this. On the right-hand side, you can see that there's a key for the species. These are the 3 major complexes. So minimus is a blue circle, maculatus is a red square, dirus is the green triangle. And if I'm showing it here, that means that it was caught outside of the house. If I'm showing it here, that means it was caught inside of a house. And along the x-axis is the time, so 6 p.m. to 6 a.m. Each of these was an infected mosquito. What I'm indicating here is right here between 6 p.m. and 7 p.m., we caught 5 Anopheles minimus and 1 maculatus inside of the house that were infected. And the big takeaway from this is that most of these were occurring in places and times that you would not have been protected by something like bed nets. Because bed nets work when you're underneath them, which happens when you're inside your house and you're in bed probably. So if you don't go to bed before 9 p.m., which most people do not, they're going to be sitting on their porches, drinking beer with their buddies, hanging out. Or if you wake up early, like many Korean farmers do, at 4 a.m. to get ready to go out to the farms, then you would not have been protected. Or if you're not laying down inside your house under the mosquito net, then there's all these that were detected at the same time. Move into the biomarker work a bit. It's kind of a complicated figure. So what I've got here underneath is a smooth map of the immune response to Anopheles bites. Where it's really dark red, that indicates a hot spot. That's where people that were living in these houses, they're the little gray points here, they have a higher than average immune response to Anopheles bites. People that are living here are getting bit by a lot of Anopheles mosquitoes. The catch sites are indicated by the orange circles, and they're graduated cylinders. So the bigger the human biting rate, the bigger that circle. The human biting rate that's the number of mosquito bites per person per month. So right here, you've got one that's about 468 bites, Anopheles bites per person per month, right there. And what we found, we used a linear mixed effects regression. We controlled for things like age and sex in the survey period. And we found a very strong correlation between living close to one of these catch sites with a high HBR and the immune response, your immune response. What that means is if you live close to one of these catch sites with a lot of mosquitoes that are biting, then you also have a high Anopheles response. It seems kind of obvious, but if you go back to the dogma that all the malaria is happening in the forest, and the fact that we're catching mosquitoes in the village with malaria parasites in them too, then it's at least probable that some of the transmission is occurring within the village. The other takeaway from this is that you can see that it's relatively widespread, these hot spots of Anopheles bites. And I've indicated here that it's the wet season, but you can look at the same map from the dry season, and you can see that it's a little bit less widespread. You still have some hot spots, but they're kind of like little islands. And they're not occurring next to places with really high HBRs. The catching sites here, 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 here. This one's a little big. And this is interesting because some of these are occurring you've got a hotspot that's not next to a high HPR. So this means that people are still getting bit by Anopheles mosquitoes, but maybe not in the village. So perhaps during the dry season, so in the wet season, there's lots of mosquitoes. There's even infected mosquitoes within the village. Transmission could at least be happening in the village, but sometimes it seems like people may be exposed to mosquitoes outside of the village, which seems common sense enough, I think. What this means is exposure to vector sometimes occurs outside of times in mosquitoes when normal mosquito-based interventions would work, so mosquito nets and indoor spraying. Exposure also likely occurs in many places. That's indoors and outdoors, in the village, outside of the village. And this also means that a house or village-focused approach may not be sufficient to completely disrupt malaria transmission, at least in this area. The next topic, the next question, was about reactive case detection. So that is, can we spatially target cases at a very fine scale? And this approach, it's spatially intuitive. So if you're a space-time analyst like me, you really kind of like the idea of this approach. It's based on an index case from passive case detection. If I was a malaria post worker, for example, and I have a symptomatic person come to my malaria post, not only do I diagnose and treat that person, I go back to their house and I screen people in their house. Or I might also do some kind of a radius around their house. So to their neighbors, I'll screen their neighbors as well. And it's based on this idea that infectious diseases tend to cluster in space and time. It's listed in all the greater Mekong sub-region national malaria strategies, and this approach has been promoted by the World Health Organization specifically for low transmission settings as a tool for elimination. And so what we wanted to do was we wanted to use our data, our empirical data from these 4 study villages to see if reactive case detection would have worked had we used it. The way I did this was using a spatial simulation. Each of those villages has a malaria post, and when a symptomatic patient comes to when a person comes to the malaria post, regardless of symptoms or diagnosis, their ID code from that demographic surveillance system is written down, and you can map that person back to their house. So in panel A here, what I've done is each little dot indicates a household within the village, and the ones that are colored, these brown diamonds, those are households who had clinical PF cases in month X. And then I show in month X+1, so it's the next month, clinical cases in blue, also showing the previous ones. And after I do that, I can create a 50-meter buffer around those households from month X and see what I might have detected if I'd used a 50-meter screening radius in the next month. Right here, you can see that these are the buffers around those original cases from month X, and I would have detected these using a 50-meter radius, but I would have missed these, I would have missed these, and these. But then I toggle that radius up by 50-meter intervals. So it goes it starts at about just the house level to 50 meters, 100, 150, all the way up to 500 meters radius, which is pretty large. And at that point, I'm detecting most of the cases. I'm just missing this one here. And then I repeat this for all 4 villages for every time step for each month during the study period. And the first result that comes out of this is that 50% of the screenings would have resulted in no detected cases, not because of the approach per se, but because there were no cases to detect, because this is a low transmission setting. These are case data from one of the study villages. On the y-axis here, I'm showing the case numbers. This is 2 cases, this is 1 case. And on the x-axis, I'm showing the month during the study period. At month 1, you had 2 cases, but it was followed by 1, 2, 3 months where there were no cases. And then you had 2 cases in month 5, followed by no cases in month 6. So this would have resulted in a screening, but there would have been no cases to find. And this is how it normally works in a low transmission setting. It requires a lot of work because you're going to have cases. You're going to have to go out and talk people into giving you blood because even though they don't feel sick. And then you might have to start all over again if you have another case. And most of the time, you're not going to find cases. The next result are that at larger screening radii, you would have detected most cases at the larger radii. On the left-hand side, what I'm showing is the proportion of cases detected along the y-axis and the screening radius that would have been used here. At 5 meters, you're only searching within the house, and you can see that at about 150 meters radius, you're finally getting up to almost all of the cases. Just searching in the house, you would have detected almost 20% of the malaria cases, which isn't bad. You're detecting more cases, but you're not going to break transmission that way. If you're getting up here, you're above 80%, that's pretty decent. But at the same time, I'm showing the proportion of houses that you would have had to have screened to have done that. And at that same 150 meters radius, you're detecting you're screening almost all of the households in the community, which is a different approach altogether. It's not really spatial targeting. And if you have those sporadic cases like in the previous slide that I was showing you, like this, you're going to be rescreening the same people over and over again. At some point, that community is going to get tired of you showing up and wanting their blood. Sometimes it can be hard to begin with. And then the final way that I looked at this was with random targeting. On this side, this is the same slide this is the same panel that I showed from before. So at just searching in the house, you're getting almost 20% of the cases. Another way to look at this, though, is if I would have screened 5 houses here, what if I just randomly selected 5 houses without spatial targeting in the same community and see how many cases I would have detected that way, or the proportion of cases. You can see if you just look in the house, you're doing better than random. But if you get up to about 150 meters radius, it's almost the same. And above that, it is the same in fact. So that means if I would have screened within 150 meters radius, say I screened 20 households that would have all been clustered around those index cases from the previous month, I could have just randomly selected 20 households in that same community and I would have done almost as well at larger screening radiuses. So what I take from this, combined the vector work and the reactive case detection simulations here, is that because of the complex spatial transmission patterns, because people could be getting infected in the village or they could be getting infected outside of the village, it's difficult to detect spatial clusters within a village because mosquitoes are in the forests or in the farms, so not just in the village. And that means that current vector-based approaches and small-scale spatial targeting are probably not going to sufficiently halt transmission in this area. That leads me to a little bit larger type of an intervention that happens at a community level. And so my two main questions here are, what is the impact of early diagnosis and treatment on P. falciparum incidence? And what are the relative contributions of mass drug administration and that EDT, that early diagnosis and treatment, for reducing PF incidence? For this work, we had a major scale-up. All of this work is done in Korean state, so this is the conflict area. We began with mapping villages and hamlets. I've mapped over 1,400 villages and hamlets in the area so far. What I mean by mapping is not that I took a point for every single house in every village, because that would take a lifetime, but we took 1 point per hamlet, and then we wrote down some basic information like the name of the village, how many households, whether or not there are malaria services already in the village. And the reason we had to do that is because there hasn't been a proper census done in Korean state since before World War II. There was a census in Myanmar in 2014, but they did not allow census workers into these areas. They're still not receptive to the government coming in. So we're starting with no information. We needed some baseline information before we began to scale up. And at this point, as of this month, we've got 1,220 malaria posts that are operating in the area. So we went from 4 to over 1,000, and it's an area of about 18,000 square kilometers. It's a relatively big area. We randomized these villages, so each of these villages winds up with a unique identification code, and we randomly selected 300 of them for surveys. When they get selected for a survey, we send a survey team there, they take whole blood, they use a qPCR approach, and we estimate a prevalence. And when we find a high prevalence village, we started mass drug administration. And our operational definition of a high prevalence village here is if there's more than 40% malaria of any kind, 20% of which is PF. It's relatively arbitrary, it's just an operational definition. And then after we do an MDA, 12 months later, we do a follow-up screening in the same village to see if the MDA worked, to see if we've properly brought down the prevalence of malaria in that village even a year afterward. The way this looks is you can see the original 4 study villages that I was showing you earlier here. They're the black boxes with the green, fluorescent green outline. And then we scaled up to this. The blue squares are where we currently have a malaria post operating. If there's a yellow dot behind it, that's a village that we don't yet have a malaria post in, usually for complicated political reasons. We'll get there. On the right-hand side, the pink dots are where we've done a blood survey. So we've done a screening. I guess I should say, so roughly 300 kilometers from here to here, whereas it's about 100 kilometers from there to there, from the northernmost study village to the southernmost. The reason we're able to do this is because these malaria posts are really easy to set up. This is not like a gourmet restaurant. This is a little bit more like McDonald's, where you just kind of get the job done in a really simple way, but you can repeat it really easily. You can do it over and over in lots of places. The malaria posts, they're staffed, trained, and paid community members. It's somebody actually from the community. Some of them are medics, but not all of them. But they've been trained to use a rapid diagnostic test to test for malaria. This looks kind of like a pregnancy test. You prick someone's finger, you put a drop of blood on it, and you get a line that indicates whether or not they have PF or PV. They're stocked with these rapid diagnostic tests and antimalarials, and weekly data is sent back to the headquarters. And this was quite a feat. People told us we couldn't do this because a lot of the areas are very remote, difficult to get into. So areas that we could use a cell phone, a lot of areas you can't, but if they could use a cell phone, we set up an application on a smartphone, and they enter in the weekly malaria post data there. So it's the number of people that got tested, the age and sex of the people who were positive for PF or PV, and what their stocks are looking like. That way, if they start running out of RDTs or antimalarials, we can get some stocks to them before they actually run out. And other places where they don't use SMS, they're literally porting it. So it's papers on the back. They're walking to the nearest river, putting it on a boat or putting it on a motorbike. At this point, over 90% are actually reporting every week. So it's pretty amazing. And the reason that we thought that a malaria post would work, the reason we knew that it should work, is because of the biology of falciparum. When you first get sick, you're not necessarily infectious. It takes time to develop these, the gametocytes. You have to have this sexual stage of the parasite in your blood for a mosquito that bites you to actually take the transmission or take the parasite away from you. Then it undergoes another couple of cycles in the mosquito, and then it can bite someone and spread the disease. But these, they don't emerge as soon as you feel sick. And what that means is if you can get infected people to, as soon as they feel a fever, as soon as they're feeling bad, to go get tested and treated, then they shouldn't even have the sexual stage in their blood yet. So it's just about early diagnosis and treatment. And even if they do already have gametocytes, we give them one single dose of primaquine, which clears the gametocytes. It's an anti-gametocidal drug. So that means that even if they are already infectious, you halt that transmission right there. And these are RDTs. This is what I was telling you about. So these are all PF positive. You've got to control PF. Actually, these are all unique. They all have mixed infections. So these are people that had more than just a PF infection. Maybe PV, PF, PV, PO. And we get a pretty stark effect from the malaria posts. On the y-axis is incidence. This is the number of cases per 1,000 people per month. And on the x-axis, it's the age of the malaria post. At month 0, that's when the malaria post opened. That's the first month. And this is up through the 2-year period the project's been going. The red line is for PF, and the gray line is for PV. PF is falciparum malaria. And you can see that there's pretty stark decline in PF with the age of the malaria post. And at this point, we're down pretty close to 1 case per 1,000 people per year. It's pretty close. Still wiggling around a bit. We have less of an effect on PV. And that's because the biology of PV is very different from that of PF. PV has a long latent period. It hangs out in your liver for a long period of time. And the only way to clear those liver parasites is to take 7 to 14 days of primaquine. That's that gametocidal drug. But if you have a genetic disorder known as G6PD deficiency, then that 7 to 14 days of primaquine can make you very sick. It could even kill you. And we just so happen to have a very high prevalence of G6PD deficiency in this population. It could be up to 20% in some places. So we can't give primaquine at the malaria post at this point. And that's why you see the big effect with PF, but not so much with PV. When they come to the clinic, we clear the bloodstream, but they're probably going to get sick again in the future. And the next results are from the surveys. Every colored dot on this map over here, on the right-hand side, is a place where we've had a result back. And the red diamonds are places where we had a hotspot and we MDA'd. And what you can really take away from this is that they're really clustered. So almost all of the hotspot villages, those high prevalence villages, occurred up in this northernmost area. This also happens to be the most remote part of Corinne State. I'll zip through this, but this just indicates that there's a lot of clustering of these. It's a clustering statistic with the higher values indicating more clustering, and the x-axis is the distance between points on the map. So right here at 15 kilometers, villages that are within 15 kilometers of each other have very similar prevalences. So high prevalence villages tend to be really close to other high prevalence villages. From the 12-month follow-up surveys, we've got the initial surveys here with confidence intervals. So this village had a prevalence of over 32% of PF. It's pretty high. And at the 12-month follow-up, it's down at 0. You can see that, especially for the ones that were really high prevalence, we had a stark effect. The ones that had lower prevalence at the beginning, it's a little bit difficult to beat them down. But overall, really good results from the MDA. Another way to look at the impact of the mass drug administration is to look at the incidence. So once again, this is 1 per 1,000 per person, or 1 per 1,000 people per month. And these are just the hotspot villages. And then we do an MDA here, and you can see the incidence after MDA. It doesn't completely go to 0, but it really knocks it down, and it does so really quickly. So what we're interested in is what's the relative contribution of the malaria post and the MDA for knocking down the PF incidence. And we used a mixed effects negative binomial regression to look at this. So the outcome is the incidence rate ratio. And very briefly, a ratio of 1 means no effect at all. If the ratio is under 1, that means that you're having a reduction. If it's above 1, that means that it's higher in that one than the control. So the first thing we look at is MP coverage in a village tract. This is an administrative unit. And we say for every additional 10% in coverage, so every increase in 10% of the villages within that tract that have malaria posts, as individual malaria posts, you see a 10% decrease in the incidence of PF malaria. So being surrounded by malaria posts is actually protective. For the MDA, you can see that in low prevalence villages, we don't do MDA in those. So there's no effect, that's your reference. But in high prevalence villages before an MDA, you have almost 3 times the incidence as compared to a low prevalence village. And then after MDA, we've brought it down to what a normal village would have before. So MDA makes a high prevalence village look like a normal prevalence village. And then for the malaria post, for each additional 10 weeks of being open in a low prevalence village, you get about almost a 20% decrease in incidence for every 10 weeks that it's open. So that would keep going. And then in high prevalence villages before MDA, it's even a bigger impact, almost 25% decrease in incidence for every 10 weeks that it's open. And then after MDA, it kind of makes it act more like a regular village, like a low prevalence village. So it's about 15% decrease in incidence. So what we take from this is that malaria posts, which are pretty simple, can have a major impact. MDA also does, and it really knocks down the prevalence and the incidence. But I have to tell you, mass drug administration is very difficult. It takes a lot of work. To convince the entire community to take antimalarials, even though they're not sick, is not an easy thing to do. The biggest effect that we get really comes from the malaria posts. It's what you see from this major decline, and it's because we can scale it up. We can do it everywhere. It's very simple to do. The mass drug administration, we can only do it in very targeted places. But the MDA does really speed up a malaria post effect. And some of the modeling work we're doing now indicates that the MDA, in some cases, can have the same effect as 2 years of a malaria post being open, in some cases. So future directions, what I'm interested in is why this is still wiggling about on the bottom. I'll try to zip through this real fast here. So this remaining transmission, why hasn't it gone completely to 0? And I think this is because of barriers. Barriers from being protected against vectors, why aren't you using the mosquito net, or why are you being bitten even though you're using mosquito nets, and barriers to early diagnosis and treatment. And I think what's very interesting to look at for these barriers is what I'm calling activity spaces. By activity space, I mean, in a very detailed study, you might have 1 point per person's home, but when I wake up in the morning, I go to work, and I spend 8 to 10 hours at work, and then after I leave work, I might go to the market, maybe I'll go to the bar, and then after that, I go back home and I'll spend another 8 to 10 hours there. Now, assuming there are infected mosquitoes everywhere that could infect me, if I wind up with an infection, I could have gotten it at home, or I could have equally as likely gotten it at work. I could have even gotten it at the market, though since I spend less time there, it's a little bit less likely. And the way I want to get at this with Karen farmers, you can think of as living in villages with gardens on the outside and paddy fields and then forests on the outside of that. The human population density kind of centered around villages in very specific times, so after the harvest season, during holidays, and then at other times being centered on the fields where they're literally living in the fields. Many of these people will spend half of their lives in the paddy fields. And those environments are very different. It's a very wet environment. Lots of mosquitoes out there. This is a rice paddy field. So I started mapping out farms. These are the original 4 TCE villages, or the 4 study villages that I showed you earlier. The green dots are homes or houses in the village, but the brown squares are farm huts. Most people will have some kind of a farm hut that they can live in when they're working in the fields. So we went out and we mapped out their actual farm huts, so now we're looking at whether or not clustering occurs in the farm huts, and we're trying to set up mosquito trapping out there to see if we can catch mosquitoes in those that have parasites. But even that is an oversimplification, and this is where a bit of anthropology comes in, because while most Karen people are farmers, not all are. Some of them are mahouts, so they have domesticated elephants. They haul heavy teak logs through the forest, and they have very different activity space patterns than do farmers. Others are boat drivers. They make a living by moving things across the river or up and down the river. And still there are hunters, there are soldiers, there are many different activity patterns. And the way I want to get at this is using this, GPS loggers. I want to empirically measure these activity spaces. I think I even brought one. This is what it looks like. These are the real ones here. And I'm talking rural Karen villagers into taking these and wearing them at all times. And the research questions that I have with this are, where are people spending their time, and can we narrow down where people are acquiring infections? And this is some example data from one farmer, from 1 week of data. You get a point every 30 minutes is what I've set them on, so they just automatically take a point every 30 minutes. And underneath each of these points on the map, there's a latitude, a longitude, and a time. You get a timestamp. And from that, you can turn the data into something like a heat map and see where they're actually spending their time. This happens to be this farmer's home and his farms. From this, we can start to look for risk areas. So if you have a cohort of people that are doing this, some of them wind up with malaria infections, some of them don't, then you start aggregating their data and seeing if they have different activity space patterns. The main research questions are, can we identify spaces and times in which transmission might be occurring? If so, what mosquito vector species are out in those places? Because I expect they'll be different than what's in the village. And are those mosquitoes infected? And then, if we can narrow down these danger spaces, what's the best intervention? Do we need to talk people into wearing insecticide-treated clothing? Do we need to set a malaria post up in the forest or in the farms? And start to think about how to disrupt transmission when we find where it's happening. And then finally, can these approaches also be applied to other regions? So can we do the same thing in Cambodia and Laos, other places, maybe even in Africa as well? And can we apply this to other infectious diseases? What does this kind of work mean for tuberculosis, for HIV, for other things that are important? And so in summary, complex transmission patterns make the small-scale targeted interventions very difficult to do. Community-level stuff works really well. It's effective, it's scalable, but it might not be enough to completely reach elimination. So I think what's warranted is some very detailed understanding of human-environment interactions. And then the questions are, is it scalable? Can we make it scalable? Are there operational implications? And can we do it with other places and other diseases? And lots of people to thank. My boss, Francois Nostin, communities in Eastern Karen State, mapping assistance from my assistants, Sapawa and Samuel Chitmin, people from the Karen Department of Health and Welfare, collaborators from IRD in France, and of course, the big bosses, Nick White and Nick Day. And with that, thank you for coming here. 45 minutes, sorry if I'm a little late, and I'll answer any questions. And this is one of my mapping teams from the Scale It project. Yeah. They're great. They even smile when in the rain, huh? Yeah. So MDA for malaria is controversial. Okay. They do it for other diseases like filaria a lot, and it's less controversial. I don't know why it's less controversial, because for filaria, if you actually have worms in you and you take the antifilarials, it makes you sick. And from our studies, we don't see many people getting sick. So we think it's pretty safe. And in fact, when we go do it in one community, sometimes we'll find that if there's a neighbor community that's very close by, the villagers get upset and they want antimalarials too. They don't know why this community is getting it and they aren't. So people are pretty accepting of it, generally speaking. One concern, though, is that you could more quickly drive resistance. It's a big selective force. But we think that it's actually, if you think about it, most of these people have very low levels of parasitemia. So this is below a level that you could actually detect by a microscope. Very few parasites. When you have one person that comes into a community and they're really sick, they're hyperparasitemic, that person has more parasites in them than almost the entire community of submicroscopic carriers. So we think by treating them, it's actually safer for drug resistance than having these symptomatic patients. So the normal treatment when you're treating symptomatic people, we think is really what's driving resistance, not doing an MDA on really low-level parasitemia cases. That's our approach, yeah.
Aside from the Thailand and Myanmar border, is this program being implemented anywhere else? Because it seems remarkably impactful. Is it being used in any other regions of malaria?
So there are, the original 4 studies, that has been redone in Laos, on the Lao-Vietnam border, on the Cambodian border, close to Thai, in Cambodia close to the Thai border, in Vietnam, and other places of Myanmar as well. The scale-up of the malaria posts has been done in a lot of places, but what we argue with people a lot about is whether or not they should be volunteers or whether or not they should actually have a paycheck. We think they should have a paycheck, and that will inspire them to keep the job longer. but other people disagree with this. Yeah. Yeah. Mm-hmm. Yes.
Sorry. This is so fascinating to me because I've spent so much time in the border region here.
Mm-hmm.
And I'm just wondering if you take into consideration how the conflict impacts transmission, because it's so, that to me is part of the spatial human environment pattern.
Yes.
And then also the rates of deforestation, because when I was there was so much deforestation happening on both sides of the border that I just wonder what the links are between that conflict and what you're studying.
It's complicated. In the refugee camps, actually, people have relatively good health because they have ready access to even education as well. So ironically, sometimes the people that wind up in a refugee camp are better off than people that still live in Karen State. But if you actually live in the conflict area, then it's a problem. There was some fighting recently close to a place where they want to build a dam, and 4 of our malaria posts got burned down, and there's a lot of movement around. And then it's not so much a malaria problem, but when people have to move quickly like that, then you have sanitation issues and other things. So that's a real problem, especially in immediate conflict areas. The deforestation, I think it really knocks down malaria. So if you really want to eliminate malaria, just cut all the forests down. Then you have dengue, but it's a terrible solution, but it really does, yeah.
That's been shown differently in different places, right? And
Yeah.
other vector-borne diseases rise as a result of deforestation.
Exactly, yeah, you trade malaria for dengue.
But do you take into account the conflict at all as a confounding variable in your study?
No, we haven't. Real conflict where there's actual fighting isn't that common.
Okay.
But there are places where we have trouble setting up malaria posts, and the reason is because of that. I don't have a good answer for you on that. Yeah, it is a very important thing. Yeah, it's complicated.
The outdoor transmission is a very serious problem worldwide.
Yes.
It happens in Africa, Asia, South America. So in your study area, are people using the spatial repellent to repel mosquito?
They've been talking about it, but I haven't seen it done yet. Yeah, but I think it's a very interesting approach. Spatial repellents, where you actually have some kind of a repellent set up in a specific place. It just makes mosquitoes not want to be there. Yeah. But people are talking about it. Yeah, I haven't seen it yet.
Dr. Yan, one more question, and then I know that people have to go to class, so please.
Nice talk.
Thank you.
My question is, when you compare before and after MK, do you consider the coverage of vector intervention, like FedNets and IRS, between during your study period as well as between study period?
I'm working on a way to try to do that, but it's very difficult. In the original 4 study villages, we do ask people how much they use bed nets, and so we have a self-reported measurement of it. But people, I think people, they lie about it a lot because they know they should be. So if you ask them, do you sleep under a bed net? They're like, oh yeah, of course. Whether or not they do, I don't know. For the big scale-up, we don't have that detailed of data. I think the best I could really do is, I know that we distribute lots of bed nets, and so we could maybe account for, we distribute this many bed nets in this area and this many bed nets in this area at a certain time. But that's probably the best that we could do. And we haven't really done anything else like outdoor spraying. We haven't done. We've tried it in a very targeted area, but people get really, they're a bit suspicious about it. And if the livestock dies or anything, then we're in trouble.
So if you would like to continue the conversation and you're available, we'd like to invite you to lunch in the Anteater Instructional Building, 2nd floor in the chair. One more round of applause for Dr. Parker.
Thank you.